Welcome, everybody, and it is now 12 o'clock. Good afternoon. Welcome to the Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'm happy to be today's facilitator. To help us with attendance, we ask that you please type your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon in the navigation bar of the Zoom toolbar. If you're joining via phone, please email your phone number and your name to cstat@uthcsa.edu. We hope that you'll join by video for the discussion portion in the latter half of the session, but regardless of how you're joining us today, we're just happy that you're here and learning alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we do ask that you stay muted unless you are speaking. There's a lot of us in this space, so be sure to keep your comments brief so that others are given the chance to share as well. And finally, please note that no protected health information is allowed in either our chat or in the discussions. Our didactic today is on overdose prevention strategies for reducing maternal mortality associated with substance use disorder, and is presented by Dr. Anastasia Ruiz, an assistant professor with the Department of Psychiatry at Texas Tech University Health Sciences Center. Following that, we'll have a case presented by Dr. Rolf Luckner, and we'll start with introductions, followed by the didactic, announcements, the case presentation, and then open discussion. Thanks again for joining us today. I'll start by announcing and introducing our Hub team members. Dr. Subrin.
Hi, good morning, everybody. My name is Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health, and I work in a integrative health OBGYN clinic. So I'm embedded here in an OBGYN office. And I have been in the outpatient women's health for almost 8 years, and prior to that in inpatient women's health for about 10. And I'm so happy to share this topic and this time with you all.
Thank you. Dr. Humphrey.
Hello, everyone. I'm Dr. Humphrey. I'm a DNP that is currently in Waco, Texas, and I've done both inpatient and outpatient addiction medicine for about 12 years now, with a focus on women.
Welcome. Dr. Chaudhry.
Hello, everyone. My name is Ali, and I am an assistant professor and the director of adolescent and youth clinical services at UT Health San Antonio. And I run the Be Well Texas Youth Clinic, which serves patients with substance use disorder from the ages of 11 to 27.
Thank you for being here. Dr. Alag.
Hi, everyone. Sorry, I'm driving as I'm listening into this. But hi, everyone. I'm Purvanshi Alag. I'm one of the assistant professors at Texas Tech University Health Sciences Center. And I'm also the director for addictive disorders in the Department of Psychiatry at Texas Tech, and excited to be here.
Thank you for being here. And I'll save our final Hub team member for her introduction when we transition to our didactic. And again, welcome Hub team members. Thank you for participating in today's session. And now, Dr. Ruiz, I'll hand it over to you. We're glad to have you as a presenter and as a Hub team member. Welcome. You're muted right now, Dr. Ruiz.
Thank you. Thank you. Hi, everyone. Thank you for being here. I am so excited to be here presenting on this important topic. My name is Anastasia Ruiz. I am a physician psychiatrist, and I am a assistant professor at TTU Health Sciences Center in Lubbock, Texas. And what I do there is I work with the residents. Every morning we have a perinatal clinic, and we treat women planning to get pregnant with postpartum. I also am part of the PeriPAN program, where any clinician that has any questions, whether that's referral therapy options, treatment options, and medication options, can call into our PeriPAN number, and you will get a response, usually within 10 minutes, but always within 30 minutes. And we can give you some consult recommendations while your patient's still in the room. So I'm staffed that service, and I am so happy to get to talk to you, our callers, just get to help get to know you guys and help make sure that our patients are connected with treatment without any delays. Thank you.
Are you ready to move on to your next slide?
Oh, sorry. So we'll go ahead and start today's presentation here. Today's topic is on overdose prevention strategies for reducing maternal mortality associated with substance use disorder. And the previous slide, real quick, I just want to, Brent or IT, if you can go to the previous slide.
We're on the title slide right now.
Gotcha. Okay. We had is it the next? Okay, go to the next slide. I want to just highlight that October was our substance use and misuse prevention. There we go. Thank you. I got it all mixed up. Sorry. Thank you. So October was our substance use and misuse prevention month. So I just want to highlight that, and we continue to make sure that we are recognizing this every month, not just October. Thank you. And the previous slide there, I had no disclosure and no financial conflict there. And views expressed today don't necessarily represent our associated institutions. Next slide. So we have three main learning objectives today. The first one is we will identify prevalence and leading causes of maternal mortality related to substance use disorder and overdose. The second objective is we will apply evidence-based overdose prevention strategies during pregnancy and postpartum. We will also go over use of timely referrals to connect patients with appropriate treatment and recovery support services. Next slide. So just I want to go over some definitions here. I know that the topic today is on maternal mortality. And when we think of that word, we think of mortality related to being the maternal phase. But just some definitions, we're on the same page because as you look at literature and publications about this, it actually doesn't capture everything. So maternal mortality, generally speaking, actually excludes substance use related overdose deaths. So when you hear about, when the CDC or other world agencies speaking about maternal mortality, they're just talking about health conditions. They're actually not even covering mental health. That if we add that, it's a lot more. So what you'll see in literature, the phrase that we use to capture mental health and substance use related deaths related to pregnancy and postpartum, you may be seeing words like pregnancy related deaths and pregnancy associated deaths. They are sometimes used interchangeably, these two phrases, although you may see the latter, the pregnancy associated deaths are the word we're using more commonly now in literature to capture substance use related mortality. So for the longest time, maternal mortality did not capture anyone that had an overdose death. Now we are trying to capture that data much better. The terminology is evolving. Next slide. Why does this matter? We do know that substance use disorders, especially opiates and stimulants, are rising contributors to maternal mortality and morbidity. Overdose deaths in pregnancy and postpartum women tripled from 2018 to 2021. We know that 16% of pregnancy-associated deaths were overdose related, mostly outside of hospitals. What does that mean? So we know that when people have any pregnancy complications or emergencies, they do make it to the hospital for treatment. However, when we look at overdose deaths, that often happens outside, meaning that the patients are usually at their home or where they were living at, and the overdose was very sudden. It happened without any intervention. The patient never received treatment. Just to compare some numbers here, when someone has a obstetric emergency, the inside the healthcare setting, uh, 78% of the obstetric deaths from medical complications happen in the hospital. 78%. Meaning that when someone had a obstetric emergency, 78% of them made it to the hospital, but because of the intervention were not sufficient, they passed in the hospital. But when we look at overdose, only 35% made it to the hospital. So the remaining actually occurred at home, outside a hospital. So these are major missed opportunities there, and we really need to change the landscape here, letting patients know that they are safe to go to hospital. If they had an overdose, if they're using substances, please go to a hospital for treatment. You will not be turned away, because that stigma can make sure that we are really elevating that number so that people know hospitals are safe. Substance use overdose is now the leading cause of pregnancy-associated deaths, underscoring the need for stronger postpartum follow-up and community support. Next slide. This is a table, and we keep showing this table in the past webinars and echoes, but it's such a good table, and I just love this table. So let's look at all of the numbers here real quickly. If you look at the last box, okay, so if you can look at the other direct pregnancy complications, these are like hemorrhages, infection, hypertension disorder, etc. This accounts for 59.3% of deaths associated with pregnancy, meaning the remaining uh, percent are actually indirect causes. Okay. Then you got 18% that are indirect, meaning they had an underlying pre-existing condition that contributed to that. Then let's look at drug overdose, homicide, and suicide. Drug overdose accounted for 19.4% of pregnancy-associated deaths in the US. That means 1 out of 5 deaths associated with pregnancy were due to drug overdose. This number nearly doubled just in that decade from 2010 to 19 versus 18 to 22, and nearly doubled. And so these numbers here, 2,083 mothers die from overdose, and that number is just not acceptable. That's 2,083 families broken. Homicide also risen somewhat, and that is another important factor here to consider. Homicide, we always want to be screening for intimate partner violence to make sure that we are giving our patient good access to care and safety, a safe pregnancy. Suicide here, we do know that the number has been steady, but suicide does account for 5.4% of pregnancy-associated deaths in the US. Next slide. This number here, substance use in the past month, we do know that pregnant women use substances. So if you look at the first table here, illicit drug, that accounts for the x-axis here, 0 to 9%. Tobacco products, that one there, as you can see, if I just look at 2020, that has decreased over the years. So we're doing a really good job, everyone. We are doing such a good job in that. If you just look at the bar, okay, the solid blue is 2017, the green is 2018, the gray is 2019, and then the 2020 is the last data bar here that's published here. If you look at that bar, we are doing such a good job. Tobacco product usage has decreased from almost 15% all the way down to 8%. We're cutting that in half. We're doing incredible there. Alcohol, that was trending down. It did take up a little bit there. And then in terms of illicit drug, we do see a down climb, but then that ticked up again as well. And out of the illicit drug, we can see that marijuana, cannabis is the number one. And then the opiate usage share, we can see the number close to 1%. And that is going down, but the number actually has ticked up in the last 5 years. And then cocaine, there is less prevalent. Next slide. Let's talk about risk factors and protective factors here. So populations at risk are going to be individuals that have a substance use disorder, especially involving opiates and stimulants. Biocycle risk factors, we look at unmarried status, lower education, unstable housing, limited social support, mental health disorders, trauma, adverse childhood experiences, and stressful life events. Clinically, when someone has inadequate prenatal care, pregnancy complications, a history of loss in pregnancy and polysubstance usage, those are risk factors as well. Barriers to care are also risk factors. So someone that has internal or external stigma or fear of punitive consequences or the lack of timely substance use disorder treatment. Now, protective factors are people that are consistently taking medications to treat opiate use disorder during pregnancy and postpartum. We do not, that is a great protective factor. Next. Um, let's talk about opportunities and challenges in the perinatal period. About 10% of pregnant individuals meet substance use disorder criteria. 10%, 1 out of 10. So that's a pretty significant number. That's double of gestational diabetes, and we screen everyone for that. We treat everyone for that. This is a very significant number here. Pregnancy motivates cessation. We do see this. We do see that when moms become pregnant, they do have a decreased usage. However, overdose risk rises sharply postpartum, peaking at 7 to 12 months. And why is this critical? Because typically, patients don't follow up with their OB 7 to 12 months after. And if they don't have a PCP that takes over that care, where maybe they really don't have anyone to check in on them. So this is where pediatricians are such a crucial role, because guess what? That mom will be taking their baby to that pediatrician checkup, and that is a critical time for that pediatrician to be screening the mother for any mental health and substance use conditions, offering support as well. We also want to remember that someone that had a loss then actually don't even have those pediatrician follow-up appointments. And if anyone has a loss, a miscarriage or stillborn, it is important that we keep them in mind, that we want to actually go ahead and schedule out those follow-up appointments 1, 3, 6, 8, 9, 12 months postpartum, or after the loss, to continue to check in on them. Postpartum vulnerability is driven by a loss of insurance. People lose insurance. They had a reduced treatment, right? They don't have to follow up as routine anymore, so they're lost in that. Stress and psychiatric comorbidities. Other barriers, stigma again, is a huge barrier. Limited integrated care and loss of follow-up. Next slide. Let's talk about evidence-based overdose prevention strategies in pregnancy. Universal screening for substance use with non-punitive trauma-informed approach early in prenatal care is important. Universal, so everyone, not just people that have the risk factors, should be screened. Initiation and continuation of medication for opioid use disorder during pregnancy, such as buprenorphine or methadone, is recommended by ACOG, the American College of Obstetricians and Gynecologists. We also want to co-manage the prenatal care plus substance use disorder treatment, integrate that with behavioral health and social services. We also want to be comfortable with safe prescribing practices, be able to discuss the risk of substances, including opiate usage in pregnancy, the risk of treatment alternatives, and how we can decrease risk. Modeling the harm reduction model. How can we reduce harm overall? Next slide. We want to ensure continuous substance use disorder care with follow-up 1 to 2 weeks through 1 year postpartum. So we don't just stop at 6 weeks. Even if mom have good screening, they're doing good, we want to continue to follow up to 1 year postpartum and longer if there's risk factors that persist. Coordinate care with the obstetrician, pediatrician, addiction specialist, behavioral health team, and social care. Provide naloxone. Anyone that is at risk of opioid use, we need to make sure that we are providing naloxone. And there's a lot of agencies now that are mailing out free naloxone available. So to that, we should be able to eliminate any cost barriers there. We also want to educate opioid use disorder to our patients and provide support to them. At the same time, we also want to remember that we are screening for suicide, other mental health conditions. We're asking about their sleep, their social issues. We're screening for intimate partner violence and asking about their housing situation. We have other PowerPoints echo sessions and webinars that we presented before, specifically talking about screening for suicide, suicide intervention, screening for bipolar depression, all of that. If you are interested to dive a little deeper, we have that recording link right there for you to pick the topic of interest. Next slide. Let's talk about some screeners. So we do know that ACOG recommends any validated questionnaire as a first-line screening method. So we don't rely solely on universal biologic testing. So urine drug screen or blood test should not be the tool that we use to screen for substance use disorder. It should be validated questionnaires. The preferences listed by ACOG are the 4Ps plus the CRAFT, the NIDA, Quick Screen, and others. We look at studies about which one really is better. Really, the answer is whatever works for you. If you have one that you use that's working well, keep using it. If there's one that's already integrated into your clinical practice, keep using that one. In terms of sensitivity, we do know that the 4P plus and the SERP-P have higher sensitivity. So if you don't have one already, we recommend using one of those two. Go ahead. So what is the 4Ps? It's four main questions, and plus will be adding the pregnancy question. So past, partner, peers, and parents. Okay, so example, you start with, did your parents ever have problem with drinking or using drugs? Then go to the partner. Does your partner have a problem with alcohol or drugs? Then in the past, have you ever had any alcohol or drug problems in the past? Then pregnancy. In the month before you knew you were pregnant, did you drink or use anything? And right now, have you used alcohol, tobacco, or drugs at any time during the pregnancy? That's it. This is a screener. This is the 4P screener. So if you can add that into your visit, you have done a universal screening in your visit. Next one. Here's a craft questionnaire. If you prefer to print out a questionnaire for the patient to use, this one is really great as well. And this is what it looks like. During the past 12 months, how many days did you, question 1, 2, 3, drink more than a few sips of beer, wine, or anything containing alcohol? Okay. Use any marijuana, synthetic marijuana, or THC products. Number 3, use anything else to get high. If they answered 0 to all 3, then they can just stop there. But if they answered 1 in any of those boxes, they would then be prompted to fill out questions 4 to 9. And that is a good screener too, if you can add that to your regular screeners. Next slide. Here's a SERP-P plus. This is another one recommended by ACOG. So it's 3 items to ask. Okay. Number 1, alcohol before pregnancy. Number 2, tobacco at any time during pregnancy. And number 3, illicit drug use at any time during pregnancy. So you probably already do this without even knowing you did a SERP-P screener, but just make sure that you are intentional about that. In terms of scoring, 0 is low risk, more than 1 or more is increased risk. And if they have more than 2, it's a high likelihood of substance use disorder, and referral is recommended at that time. Next. Clinical action by risk levels. If someone has no use, what do we recommend? We recommend that we continue to reinforce and encourage continued abstinence, rescreen in the next trimester and postpartum. Okay, provide action plan for mood changes during pregnancy and after giving birth. We have those action plans on our website, our PeriPAN website as well. If someone has low risk, we want to continue the support, provide psychoeducation, rescreen in 4 weeks. So instead of every trimester, we rescreen in 4 weeks. Okay, you can call us and call the Be Well Texas line as well if you have any specific questions. If someone has moderate risk, we want to be able to go ahead and ask about their pattern of use, cravings, impact, triggers, access issues. Consider psychotherapy and medication therapy in that visit. Want to be able to give a patient a self-care plan and a safety plan to make sure that we are screening for any suicide or overdose risk. If someone has high risk, we want to do all of the above, plus go ahead and get patient referred to a specialized service and the consultation support. Next slide. Other considerations, go ahead and look for trauma history, intimate partner violence, and other psychiatric comorbidities, and screen for infectious disease. Next. Some example languages for brief interventions in the visit, okay? Number one, I ask all my patients about substance use because it can affect your health and your baby. Your screening suggests the use of cannabis. Can you tell me more? Okay. How often do you use alcohol? Have you noticed any cravings or urges? And how does that impact your health, your pregnancy? And does it impact the caring of your baby? Okay, so space those questions out. I'm just kind of doing it back to back, but you want to kind of allow the patient to answer you. Uh, are you receiving medication, counseling, or attending support groups? Uh, and this, I love this is my favorite question. What has helped you previously? What has helped before? Um, Are there situations, feelings, or people that make you more likely to use? So these are all like great motivational interviewing questions. And by asking these questions, guess what? That is, you're already doing therapy. So I tell all my OB friends and pediatrician clinicians, like you guys are actually got a minor in psychiatry already, because I know you ask these questions. So you're already doing motivational interviewing by asking these questions. Asking these questions are part of intervention. What challenges have you faced? What's keeping you from getting the care that you need, right? Using substances during pregnancy or postpartum can increase the risk for you and your baby. You are not alone. I'm here to work with you to find the best plan for you and your family. Effective treatment and support is available. Would you like to learn more? Okay, my role is to support your health and well-being. How can I best support you today? So you just examples questions, and I know you can do that. Takes really very little time. And guess what? If a patient, a lot of times we get defeated, but just remember, we're planting seeds, planting little seeds. And one day when the patient's ready for change, they know where it's a safe place to go to. So even if the patient doesn't have any change by your intervention, keep doing it. Those seeds are important. Okay, next slide. Here's some referral pathways. Be Well, Texas, great support. PeriPAM is the perinatal access program in Texas. We have the SAMHSA treatment locator. You go to their website, you type in your zip code, and it will give you all the treatment available options. National Clinician Consultation Center is another great source, and Academy of Perinatal Harm Reduction. So you can check them out, clicking on those links afterwards. Right, next slide. So Be Well Texas referral. Here we go. We have the QI code there. The services that Be Well provides include high quality in-person or telehealth care provided by an interprofessional team. They do have treatment and medication, behavioral therapy available. Peer recovery and housing support as well, and transportation. It's low or no cost options available. Go ahead. Next slide. And I do want to tell you also about PeriPAM service. We have a direct patient consultation service. And how does this work? If you have a patient, for example, in your room, whether you are the pediatrician that's actually treating the mother's baby, or you are someone's OB, and you're just thinking, man, there's a lot to their story. I just don't have enough time, but I know the mom wants help and they need to get connected. You can call us, and right away we'll answer right away, collect some information, and the psychiatrist, like myself, will call you back within 30 minutes, usually much sooner, and she's going to give you some recommendations, some advice about what to do. Maybe you say, my mom here, she's using substances and she's saying she has bipolar and PTSD. I'm not really quite sure where to start. Well, over the phone, I'll give you some quick advice that can be initiated that same day. And then we will then get patients set up for a free direct patient consultation. So PeriPAM will actually do a virtual visit with the patient. We can extensively screen for psychiatric disorders, provide very good patient education for the patient. And this is of no cost to the patient. And we'll call you back to tell you how that visit went. Next. Oh, someone having issues scanning the QI code, I guess. Okay. Very good. All right. We'll figure that out here in a second, but we're going to go ahead and jump into the case presentation.
Thank you, Dr. Ruiz, for presenting this didactic. And we will, yes, jump into the case presentation very quickly. And for that, I want to welcome our case presenter today.
Hello, I'm Dr. Lechner. My video is disabled. It says that unable to start video.
Okay, that's okay. Are you able to see the screen?
Yeah.
Okay,
Yeah.
perfect. Oh, we see you now. Thank you.
Oh, yay. Hey. All
Yes.
right. Also, can we see the case? Oh, perfect. Yes. Dr. Ruiz, thank you for an excellent presentation. I got a lot of information from that, and the screening tools, they're very good. And I think that will make a big difference. I have a case actually of a lady that um, it's a very stressful case. I don't want anybody stressing out about this, but it is stressful, dealing with these kind of situations. I think this case will bear that out. So I'm talking about a 33-year-old white female, heterosexual, not Hispanic. She actually presented for an after hours visit. I'm a rural internist, so if somebody needs to see me on a Saturday, I live a couple of blocks away and I can come to the clinic and see them. And she was seen that way. She was actually referred by a friend who from a city, and she lives in a city that's an hour away, and she felt like I was somebody that could be trusted. So um, she she came and she was very anxious. She was withdrawing from fentanyl, 4 to 5 grams, and she was interested in treatment for her withdrawal, and also she was complaining about having trouble sleeping. And she told me that when she couldn't get fentanyl, she would take whatever she could get, hydrocodone, handfuls of it. Sh- uh, she uh, she was definitely somebody who used every day, all the time. And she's also somebody who had a number of interesting comorbidities. So I'm going to go through those right now. The mental health symptoms, I'll come back to the consult questions once I've talked about the case. So she did have depression and mania. She had a number of emergency visits. Basically, her medical care consisted of going to the emergency room and combined with brief emergency psychiatric care, length of stay 2 to 3 days for depression. Now, she was never diagnosed with bipolar disorder. And one of the reasons that I was interested in this case is because she's somebody who's usually using substances like methamphetamine or fentanyl. And at times she didn't need any sleep, didn't miss it, was making poor choices, talking fast, behaving impulsively. And she would also have this behavior when she's not using substances. So that presented a little bit of a dilemma for me in terms of knowing what I was dealing with in terms of her diagnosis. She denied any kind of OCD. She would have panic and anxiety type symptoms when she was withdrawing from fentanyl or other substances. But I don't consider that to be a panic disorder, pure. It's drug induced. Um, so suicide, she had a number of suicide attempts she was hospitalized for. She also had a number of overdoses, which is not one of the check marks that we have here, that she was admitted for. And history of trauma, sexual assault. And then, as I mentioned earlier, she was using methamphetamine. She denied using methamphetamine, but was positive on UDS. Not a smoker, doesn't drink, no marijuana, no MDMA, opioids, like I said, 4 to 5 grams per day, currently mild to, I put mild to moderate. It's actually by cows, it's moderate withdrawal. She would use Xanax and other similar substances to sleep, 1 to 6 milligrams, and she wanted me to prescribe that to her. And she, so with that, I'm going to go into the behavioral health diagnoses: opioid use disorder severe, secondary sedative stimulant disorders, also unspecified mood disorder, bipolar 1 versus induced mood disorder but due to substances, secondary mental health. She's previously been diagnosed with major depressive disorder that was severe, involving suicidal attempts. As far as behavioral health treatment, she did get emergency psychiatric care 2-3 days at a time whenever she was in a significant crises in the emergency room. But she would never follow up. She would never take the medications they prescribed her. And pharmacologic treatments, again, she would get medications when she was admitted, but she never took them as an outpatient. Scroll down. So again, we mentioned the emergency psychiatric hospitalizations. Keep scrolling. All right, so mutual aid groups, not interested in that, doesn't do that. She has significant mistrust of the medical system. She drove 1 hour to this appointment. She refused all referrals to OB-GYN and ER. She has 3 other children. They're living in another city, not where she's currently living with her mother. She told me that legally she always has to use that address because CPS is making sure that she's there with the children, which she's not. And then she was ultimately lost to follow-up and terminated her pregnancy. And then risk reduction services. At the time, we didn't have free naloxone. We could only prescribe it, and she didn't have money for that, and so she didn't get it. So prescription drug monitoring, there was one ER visit in the past 3 years where somebody prescribed her like 2 days of Norco. But other than that, no prescription medications of any kind. So can I go back to the consult questions? All right. So the questions I have are, how do we differentiate basically bipolar 1 from substance-induced mania in a newly pregnant patient who has manic symptoms with and without substance use? What's the safest non-benzo strategy for severe insomnia in a patient who refuses quetiapine? Kind of a loaded question there. And then 3, how do we balance mandatory CPS reporting with the risk of losing high-risk, mistrustful patients to all care? Number 4, what is the optimal buprenorphine induction strategy? This is kind of a teaser. I'd show you what I did. Mono versus combination naloxone, and then in the context of fentanyl high-dose use, as well as other substances. So now I want to go back to the bottom. Sorry, I'm jumping around here to the medications. So what I did is I prescribed her buprenorphine monoproduct. I don't know that I understand the logic, but people that I respect, other doctors, recommended using a monoproduct in pregnant females, and so that's what I prescribed her. 8 milligram tabs, take 1 sublingually 3 times daily, is needed for opioid cravings and withdrawal. Clonazepam is what I prescribed for her. She originally tried quetiapine to try to convince her to take it, and she said didn't want it. So I prescribed her clonazepam 1 milligram, 1 week's worth at bedtime. And then she's pregnant. She has a positive pregnancy test and a moderate opioid withdrawal with CAL score of 20. And then history of unrelated sexual assault, very storied patient. And one of those patients that's just etched in my memory. It was very, very hard caring for this patient. So with that, I'll open up for questions.
Yes, well, thank you. Yeah, like you said, a very storied patient. We thank you for presenting this information to us, for providing this overview. And now I want to encourage all of our participants, even our HEP team members, to either ask their questions aloud or to provide insights about this case. You can unmute your microphone or drop those questions and comments into the chat. And thank you for our IT support who is dropping those questions from you, Dr. Lechner, into the chat as well.
All right. So number 1, I don't know if the person wants to, oh, these are my case questions.
Yes, they are.
Very good. Well, let me try to thank you. This is such a challenging case, and although not very different from so many people with a history of substance use, you see how complicated things are. It's really not very straightforward. There's a history of trauma, a history of family mental health conditions, and compounded complex trauma. So the first thing is diagnostic clarification. So what I will want to do for her is get to the chronological timeline. How old were you when you first had psychiatric symptoms? Did it date back to childhood? Does this child have the number one psychiatric condition in childhood, which is ADHD? Did it start there? Or does she not have ADHD, but then maybe had some kind of trauma later? How was her upbringing? Which one came first and which condition collected the others? And then when was her first substance usage and did the bipolar come after? So I would get a very clear timeline and I would get family collateral history. In her case, maybe she would be open to it, maybe not. So that can be challenging. But a lot of times, family are the best advocate, and there's a complex relationship there between family. So that can be hard to manage, but collateral history is incredibly important. And so bipolar 1, if someone has no history of substance, then that's very easy to diagnose that. But when there is concurrent substance use, we would do a timeline. Have you had a history in the absence of substance use where you had bipolar 1 symptoms? If there was, and you can verify that with collateral, that's even better, then that would suggest bipolar 1 would be a comorbid diagnosis. And that can be really hard because we see bipolar 1 first episode on average in a woman from teenagers to 25 to 35. It can be any of those time range. And that probably was the time she started using substance. So it could be hard to differentiate. Um, the more important thing also here is pregnancy. So we do know that 5% of women with bipolar 1 will have at least one episode of mania during pregnancy. And 30 to 39% of women that are postpartum would have an episode postpartum. So bipolar disorder is a huge, pregnancy is a huge risk factor for exacerbation of the bipolar condition. Interestingly, we also know that about 8% of bipolar 1 patients had their first lifetime episode ever during pregnancy and postpartum. So in that question, a good detailed history would be helpful. And getting family history, because patients themselves, a lot of times they don't really know. It's a lot of questions. They have to really think about it. But building that relationship over time can help decipher the relationship there. Comorbidity is key. We do know that 20% of people with ADHD also have a bipolar disorder diagnosis, and there's such comorbidity. So having one doesn't exclude the other. I also see PTSD. When I see this patient, there's so much pain that she's medicating. She's trying, this is what she's doing. She's medicating her pain away. Where is that pain coming from? Is it trauma? When did that start? And so that's where I want to get to know. So therapy, trauma-focused therapy is going to be key for her. In terms of your approach in replacing Xanax with the Klonopin, I think that's a wonderful approach for several reasons. You give her a week at a time, meaning if she wants more, she's got to come see you in a week. That's incredible. I love that. Love that. And then it reduce overdose risk. When you only dispense 1 week at a time, it increase compliance and adherence, and it allows her to come back and see you. So that's amazing. You switch her short-acting benzo to a long-acting, which is great. What I'm concerned about this patient is we see this story all the time. Someone is using Xanax, they buy it off the streets, and it somehow laced with fentanyl, and it causes an overdose death. So I would be very worried, and I would just educate her, please, like you need to be with someone at all times. If there is when you're using, if you're such a high risk, we don't want you to be alone. And that's often you hear a lot of overdose stories where it becomes fatal is when someone's using alone, nobody even knows. And so I would educate her, please, we would like you not to use, but if you find yourself using, please don't be alone. Do not be alone. And the good news is naloxone now, it's so easy to access. You can go to a lot of state programs, put in your address, do a short little education. They'll mail you naloxone. In fact, I have two myself in my pantry. I just went to one of these websites. I put in my info, did a little education. I got two in my pantry in the case it's in my safety kit. So it's in my cart in the case that I need it, or if I ever see someone, you just never know. They do expire though, so you want to check the expiration date and get an updated one. For sleep, mirtazapine is a great medication for her. But I would be curious why she doesn't like the quetiapine. I would get more history. We also have other dual orexin receptor antagonists, but those will be pricey. So those may not be an option for her. Anyway, that hopes that answers that question. And I'm going to let other people take over in some of the other questions too.
Thank
Awesome.
you.
I love that. I'll jump in. I can jump in on questions 3 and 4 a little bit. I think the mandatory CPS reporting, that is so tricky. And when I've been practicing 12 years. And when I first started, I was kind of trained of do this anonymously. Don't let the patient know what you're doing. You don't want to mess up that relationship. And the longer I've done this, the more I found out that really messed up the relationship. Then the patient ultimately found out it was me, and then there was more distrust. And so I've switched that. And almost every time now, I let the patient know. And I say, listen, due to regulatory laws, I do have to report this. And I know that is really stressful, but I'm going to be with you every step of the way. I'm going to be honest and upfront with you, and I'm going to let you know what's going on. And usually they appreciate the respect that offers them. It's always a difficult conversation, but I have found that it usually goes better that way when they do know what's coming and they don't feel blindsided. And then we have a better relationship in the future moving forward. And I've done that with patients that I've had years and years and walked through them with that. So that's my quick note on that. I'm sure others have experiences as well. And then on question 4, the optimal buprenorphine induction, that's really tricky. I'll say monoproduct versus combination. We used to recommend monoproduct, but that was based on a theoretical risk of naloxone impacting the fetus and causing withdrawal symptoms. That was all theoretical, and really we don't recommend that anymore. I've had moms that come in and they're like, hey, I really don't want to put anything extra in my body that I don't have to during pregnancy. I totally get that. And so if they request that, I'm all for it. But I'm not necessarily going to bend over backwards to do that or take someone off a combination product if they're stable on it and all that. So we're used to we would. So it really doesn't make that big a difference. Regarding the optimal way to induce somebody, some of this depends on the substance. Fentanyl is going to make it trickier, especially during pregnancy. So I've shared it a few of the other sessions, but there's a microdosing way you can do it. That's usually what I prefer in pregnancy. It can get really complicated. I like to stick with the analogy of you're getting in a pool very slowly, a cold pool. So I start a lot lower than I typically would. I usually use the films because you can cut them very easily, and we just ease into it. And I want to minimize withdrawal. And with a lot of the guidelines out there, they continue to use the full opioid agonist like fentanyl, which we hate recommending, right? But use that the first few days as you're onboarding the Suboxone. So you're slowly taking over the receptors with time, and it minimizes withdrawal symptoms. So in pregnancy, that's typically what I recommend. And there are some charts out there that give you exactly how to do that, if that would be helpful. But I'll let others hop on.
Thank you, Dr. Humphrey. And I do see a question in the chat. I do want to allow others as well to offer their comments. But there is a question from Tamara Brown. Tamara, would you like to unmute your mic and ask that aloud?
Oh, sure. I was wanting to know if methadone is a consideration if the buprenorphine was not an option or an affordable option for her, or with the opioid history not being a high enough tolerance to initiate that treatment or make that recommendation for the patient.
So for me, I'll tell you my thought process. We're not a methadone clinic, so I can prescribe methadone for back pain, things like that, but not for this. So right away, it's off the table.
So I can probably share a few of my thoughts. Thank you for this wonderful presentation. I guess to answer one of the most recent questions, sorry, I forgot who that was, but methadone is absolutely one of the options that can be considered. It's not just from a regular or a OBOT kind of a thing. So office-based outpatient treatment has to be from a federally regulated setting. So it has to be an opioid treatment program. So I think it would be, if that's something she's willing to be on, it's great. But I will tell you, for pregnant female, it's very hard to go in every single day to be dosed. No one's going to give them the medication right off the bat. So that can be the downside of being on methadone. But if that's something she's been on and she did well on, I would probably offer some of those resources. But to answer one of the questions, I think I see that was here. What is the optimal buprenorphine induction strategy? Mono versus combination with naloxone for a patient using 4 to 5 grams of fentanyl in the first trimester. So, I mean, from my understanding and from my training experience, what I can tell is that it does not matter even if it does have a combination, if it's buprenorphine or just buprenorphine plus naloxone. The only thing is that pregnant females will report that they have some side effects from the naloxone. They feel pretty nauseous. So during those times, I might just switch them to buprenorphine. But I was absolutely, when it comes to a pregnant female, I don't know if it's fair to say, but I do actually get a little bit more liberal with them in terms of medication with Suboxone. And the reason is not that I'm going to start them off on like a 10 milligram Suboxone, but if they are telling me they've been using fentanyl, I might start them on 4 milligram twice a day, sublingual, making sure that the fentanyl has been outside of their system for at least more than 3 days. The most recent fentanyl is very potent, so it stays way longer than you would think or you would assume. Even if it is not positive in your drug screen, there could be a synthetic component which is not showing up. So I would just be very careful. I have had pregnant females who've been on like a 16 to a 24 as well, not just during first trimester. It could be further in as well. And then eventually every single trimester, you have to go up because the volume of distribution increases. I hope that helps some.
Thank you, Dr. Alag. We have just 4 more minutes for our case discussion, and I saw another question come in through the chat from John. Want to give him the opportunity to unmute and ask aloud.
Yes, thank you so much. So I was wondering if you all have any suggestions or recommendations in terms of the dental, managing the dental side effects of buprenorphine, because I've had quite a few patients who have developed a lot of dental side effects.
I would love to jump in if that's okay in answer. So we have tons of different patients who are in Suboxone. It is really sad. I do make them aware, and I'm sure we all do, that it does cause out dental concerns. And usually the reason is not directly, but more so the reason that the mouth gets very dry on any of the opioids. So even if it's not Suboxone, even if it's not methadone, any of the opioids, any of the narcotics can actually do that for that matter. So I very strongly encourage them to drink tons of fluids is one of the big things, not soda drinks because they also do mess up with your teeth, but like water is very important. I might ask them to add some cucumber or lemon to it if they really think they want to change the flavor, if they don't like the flavor of water or the taste of water. The second thing is we do provide with some community dental resources as well to our patients so they can have a regular follow-up. It takes a while, but I think it's once they get into the system, they do get seen if they have the resources for that. And then, of course, dental hygiene, we'll do some education on that as well. I personally do it, so I know for sure I would, like flossing and brushing your teeth and things like that. But it is very interesting when they are in recovery, they notice their teeth getting worse because now they're more aware versus when they were not, when they were not sober, that's when no one really cared about it. So I kind of bring that to their attention as well. It's not just the medication. So yeah.
That was a great question and a wonderful response. Thank you, Dr. Alag. With our 2 minutes remaining, want to encourage anyone else who has questions or comments about the case to go ahead and unmute.
I'll just speak for 30 seconds. Oh, sorry. Who did I interrupt?
It's me. Thank you, Joy. Interesting point I was gonna bring up real quickly. It's interesting that she denied amphetamine usage, even though the drug screen positive. But she's so open to you about all the other substance, and it just makes me think of 2 things. Number one, what is the setting that she's using? Does she even know what she's getting? And that can be really tricky. What's the setting there? So it makes me think this is more complicated than even she's aware of what she's getting. The second thing is there are several things that can cause a false positive. So over-the-counter pseudoephedrine, bupropion, Wellbutrin, trazodone sometimes can do that. Labetalol sometimes can cross-react. With her taking all these other things, I would really, I was like, this is positive. I wonder, is this something else you're taking? What could be that as a cross taper? Just kind of like, talk to her openly. And if she truly is using, I think she would then openly said, well, maybe it was from this incident. I was like, oh, well, thank you for telling me. Let's really make sure that we minimize the risk. So I found that interesting that she denied that. And it makes me think, I wonder if she's really being truthful, that maybe it was just a contamination that she wasn't even aware of.
Yeah, I didn't pursue it. Focused on the problems we did know, and she admitted to it.
Dr. Subrin, I know you can address question 3.
Oh, no, I think that was
Anything else that you
covered.
have? Yes.
Yeah, I think I was just called to a couple of points that were shared by our speaker, and by Dr. Ruiz, when I was taking tons of copious notes, and the one I underlined is, this woman is in so much pain. And I just love that you said that. I love that that's what we recognize top notch. Oh, I see all the heads nodding. This woman needs our help. So I love that you spaced her care so closely. I know that was mentioned. It says you don't have to climb the mountain. Let's take these small steps, right? That's just my language, and I think all of yours. And I just thought also that you're really breaking the mold, Dr. Lechner, by saying I live close by to the hospital or your clinic and you'll drive over. I just responded to a text myself saying I'll be there, right? When you say you'll be there, please don't exhaust yourself. Don't hear me saying, but it just changes the trajectory of these patients' lives. And this woman's in pain, and maybe she'll grow to trust. And Dr. Humphrey, saying, let's be honest about, what players have to be legally involved, and I don't want to blindside you. So anyway, just from the social work, behavioral health, the perspective, I'm so glad the members of our teams who are prescribers and experts are on the team, because I can't do that part, but I can recognize that this woman's in pain. I put in the chat the don't ever use alone or no one use alone. Where does she live? How does she get there today? An hour away. So anyway, I just taught a class this morning on the TMM model about stages of change, and we've caught her. She's moved past just contemplation. Like, she's ready for some action. So thank you for this team discussion.
Dr. Lechner, thank you so much for this case. It was pretty amazing. So thanks for bringing that case up. Appreciate it.
Absolutely. It's been a very robust discussion. And just to protect everyone's time today, we will move on to our brief announcements. We will continue taking comments and questions in the chat. Once again, you can access the chat by clicking on the speech bubble icon in the Zoom toolbar. Thank you, Dr. Lechner.
Thank you.
To receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's provided in the chat, or on the instructions on how to receive credit document that's been posted to the Content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. If you have specific questions about CME credits, please email or call the TTU-HSE CME office. You can scan the QR code, which is on the screen, or click on the link that is dropped into the chat to complete the session evaluation, which will be available until 11:59 p.m. on December 3rd. If you already have your account set up with the TTU-HSE CME office, you can use the text in attendance feature with the code 39937. This text code is only available until 11:59 today. Do you have a difficult case that you or your team have encountered? Well, let's tackle it together by bringing your challenging or complex case to the Maternal Health Echo. You'll get support from your team of experts and fellow providers. There's no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. You can email us at cstat@uthscsa.edu to present a case. That email address is also in the chat. We appreciate your continued participation in and support of our Maternal Health Echo program. Please let us know what you think about this program in the annual Health Resources and Services Administration evaluation surveys. Your feedback on these surveys is important in supporting the program's goal to increase access to behavioral health services. In addition, it will help ensure programs like ours continue to support health professionals in addressing behavioral health in the future. The survey link is available in the chat, and you can also provide feedback on the Echo or on PeriPAN's consultation line. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at the address that has been provided in the chat, and we'll be pleased to help you. We are also excited to share that CSTAT by Be Well Texas is, to take advantage of this. I'm so sorry, got caught up. I'll pass this presentation on to Jen Erdigy with PeriPAN program, who has a few announcements for you as well.
Yeah, and I think Dr. Ruiz did a good job giving a brief overview of PeriPAN. So in the interest of time, I'm just going to have you skip to the next slide. And then the next one. Let's just go right to the webinars. Yeah, thank you. So we'd love for you to join us for a PeriPAN webinar series, which is held on the third Tuesday of each month at noon Central Time. The series runs through November of 2025, but then we'll kick off a brand new lineup of topics just starting in January. We're going to be sharing these topics soon, so stay tuned. These sessions do complement the ECHO series, so offering deeper insights into perinatal mental health. And on the screen, you will see a list of upcoming topics and dates. Like I said, it ends in November. But be sure to register, and then once you register for one, you're registered for them all. And then on the next slide, you'll see just the remaining list of topics and dates for the upcoming lunchtime maternal mental health echoes, which are held on the first Tuesday of the month. We do invite you to join us in future sessions to continue learning about these important topics and engage in meaningful discussions that support perinatal mental health. Thank you.
Thank you, Jen. And with that, I'm going to turn it over to our subject matter expert, Dr. Emily Humphrey, to provide our session summary and case recommendations.
Awesome. I'm going to blow through this, guys. So really quickly, I thought it was interesting that 10% of patients, pregnant patients, meet SUD criteria. That's double gestational diabetes. So we have lots of great screening tools out there. Use them. And there's a lot of great medications out there as well. And then that first year postpartum is crucial. So schedule those patients out. Even those patients that have experienced loss, don't forget to schedule them out even 9 months, 12 months after delivery, because that's a really vulnerable time.
Thank you, Dr. Humphrey. Thank you, Dr. Ruiz, for presenting today. And thank you, Dr. Lechner, for presenting your case. As a reminder, to earn CME credits, please use the evaluation link that's been provided in the chat and email CSTAT if you have a case you'd like to present. We look forward to seeing all of you at our next session on Tuesday, December 2nd at 12 p.m. Central Standard Time. Have a great rest of your day, everyone. Bye-bye.